Well, it does seem that all the challenges have been heard, and there is movement to improve the quality measurement state of affairs. In 2016, the Healthcare Association of New York State, Haney's, published a paper entitled Moving from Measure Madness to Measures That Matter. This phraseology caught a lot of attention, including from the National Academy of Medicine's vital signs developers. These two works led to CMS and the America's Health Insurance Plans, AHIP, which is the association representing private and commercial health plans, came together in 2016 to work on core measures, much like the Joint Commission and CMS in 1999. They created the Core Quality Measures Collaborative to do three things: reduce the number of measures by eliminating low value and introducing consistency, refine measures that remain to ease the burden of data collection, and relate measures to patient health outcomes, focusing on measures that matter. 7 sets of core measures were initially adopted by the collaborative. CMS is rolling them out in stages, and commercial plans are using the measures when contracts come up for renewal or if existing contracts allow changes. The initial 7 measure sets include those for ACOs, PCMHs in primary care, medical oncology, cardiology, obstetrics and gynecology, gastroenterology, orthopedics, and HIV and hepatitis C. For the ACO, PCMH, and primary care measure sets, there are 22 measures in 8 categories: cardiovascular care, diabetes, care coordination, patient safety, prevention and wellness, utilization and cost overuse, patient experience, behavioral health, and pulmonary. The measure stewards for most of the measures include NCQA, NQF, or the Minnesota Community Measures, which we will discuss next. In 2017, CMS also reported it had started to use measures from each of the core sets. Using the notice and public comment rulemaking process, CMS has also been implementing new core measures across applicable Medicare quality programs as appropriate, while eliminating redundant measures that are not part of the core set. In addition, in 2017, the collaborative published a pediatric measure set. The measures within each set are available from CMS using the link provided in the references at the end of this unit. The Quality Measures Collaborative is conducting ongoing monitoring of the use of these measures that will enable modifications of measure sets as needed based on lessons learned, including minimizing unintended consequences and selection of new measures as better measures become available. Finally, CMS is clearly hearing the message of too many measures, especially process measures. For its Quality Payment Program Year 3, which is used in both the CMS MIPS and APM programs, CMS has explicitly stated, "We continue building on what is working and using your feedback to improve program policies. We will continue to identify low-value or low-priority process measures which will be recommended for removal and focus on meaningful quality outcomes for patients and streamlining reporting for clinicians." They are calling this their Meaningful Measures program. I mentioned that we'd talk a little bit about the Minnesota Community Measurement Program. Much has been made of the challenges in quality measurement, and the timeline has been long and very hard to get engagement. I think, though, that we should acknowledge that all is not wrong with quality measurement, and the Minnesota Quality Measurement Program is clear evidence that quality measurement can produce positive results. I had the very good fortune to see the Minnesota Community Measurement Program in action as an EHR consultant in Minnesota for a period of 10 years as physicians were first starting to roll out their EHRs. The program is consensus-based and multi-stakeholder. It has collected comparable data using primarily the HEDIS data already required to be reported by physician practices across health systems in Minnesota since the year 2000, with information about every voluntary participant, who is virtually every provider in the state, available to the public. They were really ahead of their time. Multiple state, national, and pay-for-performance programs that operate in Minnesota have now adopted the measures set, and as we saw, many measures are being adopted for national use as well in this collaborative approach to core measures. The Minnesota results, though, have been very impressive. Minnesota providers use the system to set and achieve goals for improvement. Public reporting has been helpful for consumers, but providers also review their rankings on the measurements and literally compete with one another for top scores. Some measurements actually have been retired as a result of providers consistently achieving virtually the highest possible scores. The state overall has the highest total score on overall healthcare services of all states in the U.S., and perhaps not surprising, the highest use of EHRs in the country. One example I would like to highlight for you is a primary care clinic that identified that its retinal eye exam rate was currently low and had been getting worse over the previous few years. They identified the improvements listed on this slide, which they implemented, and within 1 year, their scores rose by 20%. The improvements included patient entry of health maintenance data into a portal that connected with their EHR and allowed the clinic to see if patients had retinal exams at retail or other locations. Another one was prompts were included in the EHR for nurses rooming patients to ask about retinal exams performed elsewhere. Another one was the ability to document exams performed elsewhere being added to their EHR. Access to information about their eligible referral network supported referrals to ophthalmologists who were in network on their patients' health plans, certainly in preparation for value-based care. And at the time that I was finished working with this group, plans were being made to use Health Information Exchange to retrieve the actual retinal exam results as applicable. Other states are following suit in improving quality measurement. We've mentioned New York and the Haney's activities. The Integrated Healthcare Association in California is one of the newest such efforts, designed around bundled payment and looking to expand across the country. Today, there is a network for regional healthcare improvement that identifies more than 30 such collaboratives for improving data, providing transparency, and sharing insights to speed innovation and accelerate progress toward reform. I would note, however, that while such local work is laudable and appears to be very successful and may need to start at the local level, I hope that such work will ultimately reconcile with each other in order to ensure that we can make comparisons across regions. Another interesting example, in light of my concern I just raised, focuses more on cost than quality measurement, but just the same has had an impact on both healthcare consumers' pocketbooks as well as discussions about quality care. This is the All-Payer Claims Database Council, which was established in 2007. This is a learning collaborative focused on improving development and deployment of the All-Payer Claims Database using data from claims and eligibility and provider files from private and public health plans as specified in each participating state's mandate. Now, not all states have decided to participate as yet. As of February 2016, 12 states had all-payer claims databases up and running. 2 states, Minnesota and California, had an existing alternative structure, and 5 states were in implementation. Only 9 states had yet to express interest. Governance, funding, technology, and analytics capabilities have been challenges. Governance in particular has been challenging in some states where health plans have been reluctant to share data. The goal of the All-Payer Claims Database Council is to share learning and catalyze states to achieve mutual goals. Data are made publicly available and have led to discussions on reducing variation in cost, which has also impacted quality in a positive way, as well as assisting patients in making informed choices about their health care. 2 examples of results demonstrate the type of variation that these databases have identified and that we hope value-based care will be able to address. The Colorado Medical Price Compare identified 3 hospitals within 3 miles of each other in Denver, having a range of prices for hip joint replacement from $21,235 to $36,446 for patients with medium complexity. So no excuse about my patients were more complex or had more severity than others. These were all rated the same, but a significant difference in cost in a very small area. Why? Compare Maine is another all-payer claims database in Maine, obviously. And for surgical arthroscopy of shoulder and knee, prices ranged from $4,444 to $13,454, although in this case no patient complexity scores were identified from the source, and there could be some variation obviously there, but still this is nearly $10,000 worth of variation. Unbelievable. And again, just within one state.